Welcome to this final session of the AgrAbility National Training Workshop Encore webinars for 2025. My name is Paul Jones. I manage the National AgrAbility Project at Purdue University. And our topic today is why do my hands hurt and what can I do about it? Our presenter is Patricia Siegel, and she's from University of New Mexico School of Medicine. For those who may not be familiar with AgrAbility, we are sponsored by the USDA, and we focus on helping essentially anyone in agriculture with virtually any type of disability. Every one of the AgrAbility projects around the country is a partnership between a land-grant university and at least one nonprofit disability services organization. Currently, there are 21 state AgrAbility projects, and there's also one national AgrAbility project. Again, that's here at Purdue University through the Breaking New Ground Resource Center. And our partners on that grant include Goodwill of the Finger Lakes, Washington State, and Washington State University. If you have any interest in what we're talking about today or any other interest in issues related to disability in agriculture, please check out agrability.org. We also have about 170 archived webinars you can check out at your convenience. As I mentioned, our presenter today is Patricia Siegel, and she's an associate professor at the University of New Mexico's Occupational Therapy Graduate Program. She received her Bachelor of Science at Texas Women's University and her doctorate at Chatham University in Pittsburgh. She obtained a specialty certification in hand therapy in 2009 and has extensive practice experience in rehabilitation of the upper extremity. Dr. Siegel teaches and conducts research in the areas of orthopedics, hand therapy, and ergonomics, and has numerous publications, including the American Occupational Therapy Association practice guidelines on rheumatic disorders. So at this point, I'm going to turn things over to Dr. Siegel, and I'm going to stop sharing my screen so that she can share hers.
Everybody see it?
And we're not seeing in the slide. There we go. Thank you.
All right. Thank you so much for that introduction. I need to update that. I now have two practice guidelines. One of them was just on rheumatic disorders, and the second now also covers osteoarthritis. So I thought I'd start today by just telling everybody what a certified hand therapist is. I mean, we talk about it so frequently, like everybody knows who we are, and I find that most people don't. So I got this just off of AI. It's an occupational physical therapist with advanced specialization in treating the entire upper extremity. But basically what the bottom line is that you have to be an OT or PT. After you get out of school and pass your board, you have to practice for a minimum of 3 years. You have to acquire 4,000 hours in practice in hand therapy under a hand therapist or a hand surgeon. And then you have to pass a second set of boards, which has a pass rate of around 58 to 60%. So when I mentor people who are going to take that test, I always tell them the first thing you want to know before you take this test is don't tell anybody that you're going to take this test, because it's frequent that people have to take it more than one time to be able to pass it. So today, I'm just going to start by talking a little bit about anatomy, just so we all speak the same language. I'm going to talk about some common nerve disorders, a little bit about bone, and some tendinopathies. So the first part, anatomy. So in the upper arm, there is only one bone, the humerus. At the end of the bones are the lateral and medial epicondyles. That would be these two things right here. One of the things I always tell my students is that, you know, when you hit your elbow and you talk about hitting the funny bone, it's because it's at the end of your humerus. But it's a very important bone in the upper extremity. Bones in your forearm are the radius and ulna. The radius would be on your thumb side, the ulna on the other side. These bones rotate over each other and allow us to do things like carrying a bowl of soup and then pouring it out. Next are the wrist and carpal bones, which allow wrist flexion and extension, finger and thumb flexion and extension, and thumb opposition. Okay, so the first disorder that we're going to talk about is carpal tunnel syndrome. It is the most common peripheral neuropathy treated by hand surgeons and probably by hand therapists. It affects about 3% of the world's population at any one time. So that would be about 243 million people. Of those, only half will end up seeking medical attention, and then only half of those, so about 60.7 million people will have surgery. Etiology is mostly unknown. There are a few things that have been attributed to carpal tunnel, but for the most part, we don't really know. But we do know conditions that increase risk, like wrist fractures, arthritis, diabetes, vascular disease. And when you say vascular disease, you should also put age and pregnancy. Pregnancy, it's typically resolves after the pregnancy, after the baby is born. Some of the rest of these with wrist fractures. With wrist fractures, there's somewhere between a 60 to 80% chance that you'll get carpal tunnel after a wrist fracture. That typically also resolves when people have really serious wrist fractures. If this hand surgeon is going in to put a plate or do an open reduction, what we call open reduction internal fixation, a lot of times they'll go ahead and release the carpal tunnel just to decrease the incidence of that. The causes may be related to elevated pressure and inflammation within the carpal tunnel, and a lot of that can be caused by the work that people do with their hands. So the carpal tunnel itself is formed by two carpal bones on the sides of your wrist. In the tunnel, 9 flexor tendons and a median nerve live. So all of the tendons that create the fist and move the thumb, plus the median nerve. Part of the problem with the carpal tunnel is because there are such rigid borders, it doesn't allow for a change in volume. So, I have our students, when we go into the cadaver lab, try to put their finger in the carpal tunnel. It is really a very, very tough structure. Increased pressure in that tunnel causes compression on the median nerve and therefore carpal tunnel. So what does that mean? So first off, carpal tunnel can be transient, like we talked about with pregnancy. But sometimes when it continues, when the pressure continues, it will affect sensory and motor function of your hand. So there are basically three nerves that control the movement in your hand: the median nerve, the ulnar nerve, and the radial nerve. Carpal tunnel affects the median nerve. Sensation provided by the median nerve in your hand is on the palm side of the hand, thumb, index, middle, and ring finger, and then a little bit on the back side. But it's basically a lot of the way that we feel our world. This is the sensation that's produced by the median nerve. The other thing is like I said, all of the tendons that flex your fingers are also somewhat controlled by the median nerve. So our ability to pick up objects, like this person picking up the soap here in the picture, that's median nerve function. Specific median nerve function is also related to fine motor, like the ability to button a button or pick up a paper clip off of the desk. So those are all things that are controlled by the median nerve. So when you have carpal tunnel, it's divided into two things: sensory and motor. Typically, the first thing that people notice are sensory symptoms. So they'll notice pain, aching, pins and needles. And then typically the next thing is they'll notice diminished sensation. Actually, should back that up. They don't really notice it. What they say is, I keep dropping things. And part of that is because they have some diminished sensation. The other part of that is that nerve function also controls things like sweating. It controls your ability to get goosebumps. So what happens is that because carpal tunnel typically happens slowly, people don't realize that they're actually losing some of the ability to sweat in their fingers and some of the ability to sense. And so they start dropping things. The next part of that is motor. So muscle loss and weakness, also difficulty manipulating small objects. And in the later stages, weakness of the thenar or thumb muscles. So this picture actually shows what we call thenar wasting. I'm going to try to point that out. And that would be right in here. And typically, if you have somebody that has that much wasting in their thumb, they're not going to do very well even with surgery. So it's really good to try to get people early if they're going to have surgery. So diagnosis for carpal tunnel. The easy ones, when you go into the doctor and you complain about the different symptoms, is they might tap on the nerve, and if they tap on the nerve, actually everybody right now, if you tap on your nerve on your wrist right here where the carpal tunnel is located, it might produce an electrical symptom or a feeling of pins and needles. That's one of the easiest ways to determine if you're having problems with the median nerve. There are also some provocative tests that we do in therapy where we have a person hold their hands like this. Prolonged holding the hands like this will produce symptoms of carpal tunnel. There are sensory tests, specifically one called the Semmes-Weinstein that we do in the clinic that can map any significant sensory changes. But the gold standard and really what most people have to have prior to having any kind of operative procedure is a nerve conduction study or an EMG. So non-surgical conservative management there is some research that says it helps. People go back and forth on what works more than anything else. But if you have a little carpal tunnel, it's might as well try these things. So the first thing is to wear night splint. What we find is that a lot of people sleep with their wrists bent at night, and that increases pressure on the carpal tunnel. So taking pressure off the carpal tunnel by wearing a night splint. Exercises that you can do with the therapist called nerve glides. Contrast baths, something that doesn't get a lot of pub, but I do think it helps, is using contrast baths where you're using really, really warm water and really, really cold water and going in between the warm and the cold to try and basically bombard the nervous system. It does have some ability to reduce symptoms. I put in here modalities. Those are physical agent modalities that are done in the clinic with a therapist, something called ultrasound. Most people think of ultrasound as being specifically diagnostic, but ultrasounds can also be done to reduce edema or increase circulation or decrease pain. So there is a role for ultrasound with carpal tunnel. And non-steroidals, NSAIDs are non-steroidals that a doc might provide. And there are some physicians that will do injections, steroid injections. I think that they have become less and less. I think that there is an inherent risk. And a lot of surgeons would say, carpal tunnel is a pretty easy procedure. And I can tell you, if it was me, if I had carpal tunnel and somebody's offering me an injection, I'm probably going to say, I'm going to skip the injection and let's go to the OR. It's a most of the time, pretty easy recovery. It's just a small incision where they cut a ligament. I have a picture of the nerve glides that you would see in therapy. But they cut the ligament right here at the wrist and release the space. And like I said, when I initially talked, that space is so confined that you can cut the ligament and never worry about anything trying to jump out of that space. So it's really like with hand surgeons, it's a pretty easy bread and butter kind of case.
Dr. Siegel, we did have one question I'll throw out. Any research you have done or know of on red light therapy? I don't know if that relates to carpal tunnel myself or not, but that was the question.
I don't have any, I don't know of any research on that. And I'm trying to think of, you're talking about infrared, most likely.
Perhaps,
Um,
yes.
yeah, I do not use that modality, and it's not used very much in clinics anymore. Actually, I don't know of any clinics using it. So I'm going to have to be honest and say I really don't know of any research, and mostly because it's just not a tool that's in my toolbox.
Thank you.
I think the primary, I mean, if you're going in to take the big test in the sky, like I would tell my students, the primary things are going to be night splints, tendon glides, trying to isolate any activities that might be causing the problem. And if you can isolate the activities that are causing the problem, reducing those activities, those would be the answer for the test. Secondarily, physical agent modalities like ultrasound, contrast baths, and like I said, I don't know the research on infrared. All right, I'm gonna, Paul, if I have any more questions on carpal tunnel, otherwise,
Not at this point. I do wonder what is the recovery time for that surgery, carpal tunnel surgery?
oh, it's really so in terms of hand therapy, it's a pretty easy surgery to recover from. Um, you typically wear a splint for a couple of days. Depending on what you do, I mean, if you're an airplane pilot, they're not going to let you go back to work right away. But you usually back to normal activities within a month, but typically out of a splint and doing most of your activities in a couple of weeks. Um, and I think, most people would tell you, I don't know why I waited to have this surgery because the relief of symptoms is so immediate.
Thank you.
The second most common neuropathy in the upper extremity is probably one that people don't hear about very much, which is a little bit of a surprise to me because I see it so much. Actually, we see it when most people think they have tennis elbow. So the second one is something called cubital tunnel. So when we talk about the humerus again, that long bone in your arm, right behind one of those epicondyles is the ulnar nerve. It's right here. If you feel there's a big bone right here, the medial epicondyle, right behind that is the ulnar nerve. That's what you bump that it gives you all of the weird paresthesias. That's that you call the funny bone. That's because the ulnar nerve sits there. So, couple problems with the ulnar nerve. It is the most superficial nerve in your body. So it's going to make it far more susceptible to injury and compression because it's sitting right here. So earlier when I talked about carpal tunnel, I talked about the three nerves that control most of the function in your hand, the median, the ulnar, and the radial. So cubital tunnel is a compression of the ulnar nerve at the cubital tunnel. So what does the ulnar nerve do? It gives you sensation on the fourth and fifth fingers, but basically on the front of the hand and the back of the hand. So not quite as much real estate sensory wise, but still important real estate in your hands. It gives you force for your grip. It allows you to do pinch like key pinch or holding cards. And it allows you to bring your fingers apart from each other. The ulnar nerve is responsible for mostly the tiny little muscles in your hands. So even the muscles that allow you to bend your fingers like this are controlled by the ulnar nerve. So symptoms of cubital tunnel are sharp, aching pain at the elbow, which radiates both above and below. And that's typically one of the first things that happens. And Unfortunately, and we'll talk about this a little bit later, there's also tennis elbow and golfer's elbow that occur in the same place. So sometimes it's a little bit difficult to tease it out initially. Later on, as the nerve gets more compressed, you'll have numbness and tingling in the ring and small fingers. Once we see that you have elbow pain and you have numbness and tingling in the ring and small finger, it's a pretty easy diagnosis for a hand surgeon to make. Late stages, it causes weakness of the grip. It can cause your small finger to migrate away from the rest of your fingers, and you won't be able to bring that back in. It causes difficulty with holding things like keys. But that's obviously very late stages of cubital tunnel. This is also usually worse at night and with increased flexion or bending of the elbow. So people who sleep like this will often wake up with having the paresthesias or the abnormal sensation in their fingers and may have some aching at the elbow. Some of the causes are prolonged repeated pressure, like leaning on the ulnar nerve, prolonged elbow flexion, bone spurs. One way I always bring this home with my students when I'm talking about prolonged repeated pressure or trauma to the nerve, anesthesiologists, when they are working with a patient in the operating room, will frequently tab that area before they position the patient, because the length of the surgery can cause cubital tunnel to happen. So most anesthesiologists are very concerned about that nerve going into the operating room. This is one neuropathy that's very amenable to therapy. Therapy works for up to 80% of patients that have mild cubital tunnel. And if you go to see a therapist, the typical thing is that we're going to help you try to figure out what's causing the problem. We're going to give you something to position for night. Our first choice in this is something called a heel bow, which I have a picture of in the next slide. It not only helps give feedback so that people don't bend their elbow at night, but it protects you from any kind of force at the where the cubital tunnel or where the ulnar nerve lives. Nerve glides and modalities with the therapist. But this is one, if you have cubital tunnel, I'm going to tell you straight up, go see a hand therapist. It will really, this is definitely going to make a difference. This is a picture of a heel bow. It will cause you to not bend as much. It takes pressure off of the inside of your arm, and it helps you sleep a little bit better. So I had a patient just yesterday who came in with elbow pain, both sides. He's a musician, and everybody had been, treating him for tennis elbow, which he might have, but I gave him a heel bow to put on, and as soon as he put this on, he was like, "This is what I need." He could tell that this was going to make a difference for him. So, these are easily obtainable. You can probably find them on Amazon, but this is, like I said, one of the ones that I would definitely say find a hand therapist. All right, moving out of the nerve disorders into the bone disorders. So more than 50% of the population is affected by osteoarthritis, making it the most prevalent joint disorder in the United States. We've learned so much about osteoarthritis since I've been a therapist. When I was a young therapist, we used to tell people with osteoarthritis not to exercise, not to lift weights. And now we tell people, definitely got to lift weights. You've definitely got to exercise. So, I'm going to put it out here. If you have osteoarthritis, even, in your knees, back, whatever, it's really good idea to see a physical or occupational therapist to help you to be able to function into later years. So the hand has 29 bones. The joints most commonly affected by osteoarthritis are the carpal metacarpal, or the base of your thumb. That's here. the proximal joints of your fingers or the distal joints of your fingers. So let me see if I can find that little annotate thing. Oops, sorry. So this would be the area for CMC arthritis, carpal metacarpal arthritis. And then in the middle of your finger and in the distal portion of your finger, those are the joints most affected by arthritis. I used to work with a hand surgeon who used to say, you will at some point get thumb arthritis. So it's a very, very prevalent problem. The thumb provides about 40% of your hand function. During key pinch alone, there's a 12-fold increase on pressure at the carpal tunnel. So by the age of 80, about 40% of women and about 33% of men will have CMC arthritis. Good news for men, bad news for women is that women typically start getting osteoarthritis at the thumb much younger. So it typically starts happening around the age of 40. I think the peak is around the age of 60. Men, on the other hand, really don't develop it until later, typically in their 70s and 80s. We've learned so much about CMC arthritis, and I think we do a pretty good job with this too. So for therapy, the first thing is splinting. So we may put the joint at rest, but we specifically want to splint to remove problems at that joint. Doing stability exercises, teaching you about the patient about joint protection, and then easy physical agent modalities, a lot of which that you can own and do on your own at home. So the first one is a splint. I got the 3 splints that you're going to see most often. I actually went on Amazon today to get the cost. The first splint, this black one here, is called a Comfort Cool. It is my favorite splint. It gives support without immobilization, so it's a really comfortable splint. I have patients that I've treated with osteoarthritis who come back year after year to get a new splint from me because we have them in stock. But you can order these off of Amazon. I saw one at $20. Most of them were around the range of $32 to $35. The next splint, the one in the middle, is called a push splint. This was actually designed by occupational therapists, and so many people copied it that they finally sold, I think, the patent. So I looked today. You can get this one also on Amazon. This one is going to cost you about $100, and you're going to have to do some measuring to able to get it to fit correctly. One of the really nice things about this particular splint is that it protects the joint. It holds the joint without impact on the rest of the surface of your hand. So it's an easy splint to work in. And then the third splint is a custom-made orthosis by a hand therapist. So this is an orthosis that I made that just actually to demonstrate a particular kind of material. There are a number of different patterns that we use, and typically a hand therapist will take into consideration what the person does, their occupation, in before they try to make the splint. So step number 1 for CMC arthritis, splint, okay? Joint protection. So you have to respect pain. If you do activities that require a lot of hand function, crocheting or something like that, you have to be able to realize that you may need to break those activities into smaller time periods over the day. Try to avoid positions of deformity. Use largest joints whenever possible, and balance rest and activity. Sometimes that means reducing force by using adaptive aids, or using, bigger handles to carry objects. And I'm sure I'm probably going to get some questions about this, so I'm happy to entertain questions about that particular part of this. Easy modalities. Okay, so this is this modality is something called paraffin wax. It's wax that's heated at 125 to 130 degrees Fahrenheit. So in vivo studies where they actually measured joint temperature after the use of this physical agent modality, the temperature increased by 7.5 Celsius and in the joint, and by 4.5 Celsius at 40 degrees in the muscle. So it really does have a thermal effect on both joint and muscle. Randomized controlled trials, the gold standard, compared a control group to paraffin, and paraffin reduced pain at rest and in activity with people with osteoarthritis. So one of the really nice things about this particular modality is that it's become a relatively inexpensive modality. As a young therapist, we used to bring people into therapy and actually charge for this. Now we'll bring people in and we'll show them how to use their paraffin, but we don't bring them in routinely for paraffin. At this time of the year, around Christmas time, you can find paraffin units for $40 to $50, the smaller version, and you don't really need a large one. The wax is reusable, so it's a really nice, easy modality for people who have hand pain. So even if you don't have hand pain, if somebody that you know does, it might be a nice gift idea. This is something newer. It has, to the best of my knowledge, currently no research to support it, but people who use it swear by it. So these are just chip clips, the kind that you know, once you've opened the bag of chips and you need to put it back in the cupboard and you put the chip clip on there. The therapists that I work with get these at Target or whatever to give to their patients. Basically, just putting the clip in the web space will give some pain relief. But one of the reasons that I like to use it is because it also helps train a person where the correct alignment for their thumb is during activities, so that they're not collapsing the thumb to do activities and actually keeping the thumb in good alignment. So I put it in here because I think eventually people are going to talk about it a little bit more with research, but right now it's kind of something that we're seeing. All right, so that's kind of ran through the thumb pretty quickly.
I have a couple questions if you have a minute there.
Yeah.
One question was, where is STT arthritis?
So that's going to be between the scaphoid bone and the trapezius. So it's a little bit further down. So I would wonder if this person has some pain at the wrist and the thumb.
Yeah, that was the only question that was there. I'm not sure, but she might. Yes, she responds yes.
Okay, yeah. That's a little bit more involved. Definitely, I would definitely still look at that Comfort Cool splint because it does give some support at the wrist. Seeing a good hand surgeon, they might just go in and clean that up a little bit. But all of the same things that we just talked about here for CMC arthritis will work for that problem.
A couple others just came in, and I guess my question was, I'm not familiar with that paraffin bath. What do you do with that?
That's good. God, good question. So basically, in the paraffin bath itself, you can't really see it, but there's wax in there. That wax is it sits at 125 to 130 degrees, so it's way hotter than you can put your hand in water. And basically, you just dunk your hand in and out of that paraffin bath 8 to 10 times and get a nice coating on there. Then we have patients wrap it in a towel or something to maintain the heat for a while. And then the wax will just peel right off your hand and you can put it back into the unit. Important thing to talk about here when we're talking about paraffin. Paraffin is a mixture of actual canning wax that people use for years and mineral oil. So I believe it's a 3-to-1 ratio. I may have that ratio wrong. But so when you go to take it off, it just comes right off the hand, softens your hand. You can put it right back into the paraffin machine. There's also there are some people that use just a straight in and you keep your hand in there for 10, 15, or 20 seconds. I'm not that crazy about that. I think that's a little uncomfortable. That's why most therapists use what's, the dip, repeated dip method.
And then there
Did,
was
so
one
that
comment that indicated a concern about some of them that wax baths that have adjustable heat because some elderly patients have delicate skin. And for example, if a family member doesn't get the heat setting right, there was some concern about that.
So, to the best of my knowledge, they don't have variable heat settings anymore. I think it used to be, these things used to cost hundreds of dollars. And basically, I mean, it was wasting so much insurance dollars, having people come in to use paraffin in a clinic, that I think it started driving the prices down. I haven't seen any that have adjustable settings. But if you have somebody who's older and has fragile skin, it's a really good idea to have them see a hand therapist at least once. I don't know of any hand therapist that doesn't have a paraffin unit in their clinic for trial, just to give the person an idea. Um, you can also have paraffin treatments done at a beauty salon. They cost, I think, like upwards of $50. But it's a good way to determine if the person, will respond well. Um, the other hazard that I will say about this is that it's paraffin wax is flammable. So we advise people to not smoke or keep it away from the heat if they do use it in their home. Some of the smaller units, you plug them in like a crock pot on your kitchen counter. You leave it for 30 minutes or so and the wax melts. And like I said, that doesn't have an adjustable that I know of. The newer ones don't have adjustable settings.
Okay, thank you. We've got several more questions, but I don't want to run out of time for your presentation, so maybe we'll save some of those for a little bit later.
Okay. Okay, the digits. Um, you know, I can tell you, I'm going to just go back to CMC arthritis and STT arthritis for a minute. The surgeries for this are incredibly successful. They do have a bit of a recovery time. I mean, it's not a walk in the park, but they are very, very successful. And I think people who have them done, and I am going to say, I'm going to get my bit in here. If you're going to have any hand surgery, please see a fellowship trained hand surgeon or plastic surgeon. But the people who have CMC arthritis really do well with the surgery. Digits, most people are going to shy away from surgery at the digits. And if you do have surgery at the digits, it's probably going to be at the distal joint, and surgeons will want to fuse it. There hasn't really been a good joint replacement for the PIP joint. There is one, but it's not really that effective. So a lot of times, if you have hands that look like this, and especially if the joints are unstable, then the hand surgeon will send you to us, and we will try and talk you into doing some splinting. So there are a couple of different kinds of splints that are super effective. The silver ring splints, this is a well-established company. The silver ring splints were initially created by an occupational therapist who had horrible rheumatoid arthritis. They've probably been in business since about the late 70s or 80s. And these are basically the kinds of splints that will stabilize this particular joint. They're very pretty. You can have stones set into them, and they have different designs that can do any joint in the hand. Problem with it is they're a little bit pricey. I haven't looked recently, but a splint like this will cost you about $100, maybe a little bit more. On the other side of things, when her patent ran out, the Oval 8 company created what's a smaller plastic version. So these come 5 to a package, and I think they're about $20. They're plastic. They last a long time. I mean, unless you lose them, they don't break. And they're super effective at keeping your joints stable. The other thing I always like to talk about with osteoarthritis is that we miss sometimes stretching the small joints in our hands. And as we get older, this becomes more problematic. Most people think making a fist is good enough for keeping your hands healthy, but that is not the case. What we teach our patients is to try to make as much of a claw as you can to be able to stretch all of these little muscles in your hands. Now, when we talk about claw, that means the back of your hands and these first joints need to be straight, and then the middle and the last joints bent like a claw. And this actually, if you start working on this, like I had my mom passed when she was 95. I had her doing these exercises, and at 95, she still had a really good fist. And this will actually help you maintain your fist more than this will. So I always like to put that in every presentation that I do. All right, going to move into tendinopathies. So the two major ones in the upper extremity are lateral epicondylitis, which would be here at the tennis, also known as tennis elbow, and medial epicondylitis here, known as golfer's elbow. So what's kind of important to know is that when we talk about the humerus, the muscles that extend your wrist all start above your elbow. They cross the elbow, then they cross the wrist, and then they come in here to insert on your carpal bones. In order to make a full fist, those muscles are in play, because you'll notice if I make a full fist, my wrist comes up. It actually comes into a little bit of extension, about 20 degrees, okay? So those muscles get yanked on quite a bit, and they get tight. So, when we talk about tennis elbow or golfer's elbow, I don't at all mean to associate them with those sports. I've had tennis elbow, and I don't play tennis. Most of the people that I see in the clinic who have tennis elbow don't play tennis either. A lot of times what happens is the way they get tennis elbow is by doing something that they've never done before, or by deciding to paint their entire house in a 3-day period of time, or something like that. So tennis elbow is actually swelling or tearing of the tendons that move your wrist into extension. And they tear right up in here where they originate. It's a little tendinous insertion on a bone. Now, when I'm talking about tears, I'm not talking about a big tear. They're little tiny micro tears that cause you pain and grief. So the pain is usually pain in the outer part of your elbow at that bone right there, weak grip strength. And people will talk about, and I'm going to, because we're in AgrAbility, doing a farmer carry or something like that, and dropping whatever they're carrying because of the pain associated with the problem. And eventually it will cause you to have a weakened grip strength. So what causes it? Overuse, doing a specific event that you've maybe never done before. Greatest incidence is usually people from 35 to 55 years of age. The tendon that's really thought to be involved is the extensor carpi radialis brevis tendon, but you guys aren't taking a test, so you don't have to know that. And initially it starts as a tendinitis, which is inflammation, swelling, pain, but it rapidly moves into something that we call a tendinosis. And when it's a tendinosis, it actually creates an avascular spot on the tendon, which makes it a little bit harder to treat. So what can you do about it? The first thing is to remove the offender. And I will tell you, I have a husband who likes to do pull-ups, and his pull-up bar and his hand position is not correct, and he keeps giving himself medial epicondylitis. I tend the golfer's elbow on this side. I tell him, if you don't do the pull-ups, this won't happen. But sometimes you gotta let them learn. But if you know what caused it, try your best to not do the activity. The second thing is to use a counterforce brace. You guys have probably all seen these at Walgreens or similar. Basically, what that does is it goes around what we call the extensor wad. There's a big set of muscles right here. And when you grip, it gives you feedback to not pull forcefully. There's really mixed reviews on this. A lot of therapists will choose to just immobilize the wrist instead of using one of these braces. But this is a really easy Walgreens kind of thing or Walmart kind of thing to buy. Massage right at the area to try to increase circulation. And then going to a therapist who can teach you to do certain kinds of exercises and stretches. Heat or ice. In this particular case, patients that I actually have them do ice massage. So that's ice directly on the area until the area is numb. But this is one that's definitely worth a visit to a therapist for a couple of visits to figure out what to do. Medial epicondylitis, golfer's elbow, is the same problem, just on the other side, on the medial, from the medial epicondyle. It's the same pain, swelling, micro tears that are thought to be caused by your wrist flexors now. But I mean, whatever the cause is, you just got to kind of figure out what's causing it. Try to avoid doing it. Maybe use the counterforce brace, use heat and ice. But I try to hammer this home to my students. The biggest thing is to figure out what's causing the problem and to stop doing it, because every time you cause the problem to happen, you're reopening those little micro tears. And what we really need to do is get those to heal. The one other thing that I should have put on here is that if you go to therapy, ultrasound is pretty effective for this, at least to give you relief for the first week or two while you're trying to get those little micro tears to heal. Just a few references here that I think will probably be in the PowerPoint that I think, Paul, I think you're sending. And there are some stretching and strengthening exercises for tennis and golfer's elbow right here. Okay.
Some additional questions?
Sure.
One is asking about a recommendation for a good computer mouse.
Boy, you know what? I don't know the answer to that, and I should. We have therapists that work specifically with that, and I am not one of those. Believe it or not, my ergonomics is usually in the operating room or in the field. So I do not have the answer to your question, and I'm very sorry about that.
Yeah, I imagine it probably depends. It's pretty individualized, but I know there are quite a few different ergonomic mouses out there, so maybe some web searching would be helpful.
And Paul, if you can actually send the person's email to me, we actually have a therapist who this is her shtick. And I can ask her to give me some recommendations that I can email.
Okay. We did have one suggestion of the, I'm not sure how you pronounce it, Evoluent mouse, Evoluent, but and there's another suggestion that someone put in the chat also. Another question was about trigger fingers. And
Okay.
it just says, what about trigger fingers? Trigger
fingers. So what happens with trigger fingers is you have these pulleys that go across your fingers. So the muscles in your forearm, by the time it gets to your wrist, it's all tendon. So those tendons that go in the carpal tunnel come back through your hand, and they go under these pulleys so that your finger bends into your palm. Otherwise, it would bend like this, right? So what happens with trigger finger is the tendon is actually surrounded by a thin sheath that gives it nutrition. That becomes inflamed, often from repeated use, forceful use, um, association with diabetes, association with rheumatoid arthritis, little association with osteo, but more diabetes and rheumatoid. Once the tendon becomes inflamed, when you bend your fingers, the tendon goes through the pulley and it gets stuck. And then you end up having to pull the finger out to get the tendon to come back through the pulley. Therapists, if you go to a therapist for trigger finger, they're going to make a splint that immobilizes either this joint or this joint. So when it immobilizes this joint, then it restricts the distance that the tendon can travel. So it doesn't allow that tendon to go under that pulley. The hope is by restricting it and not allowing it to go under that pulley, that the inflammation will decrease and the it will eventually be able to go under the pulley. I have had trigger fingers and I was successful at getting rid of my own trigger fingers. My sister had trigger fingers. I was successful at getting rid of hers. However, I will tell you, it's a real iffy thing for a therapist to be able to get rid of. There's definitely very tried and true measures like splinting this joint, but once you splint it, you have to wear that all the time. On the other side of things, I will also say this is an easy surgery for a hand surgeon. It's a day procedure. It's a very small incision, and basically what they do is they go in and just create a little cut to make the pulley bigger, clean out a little of the inflammation if they can. And the person goes, is able to start making a fist, without triggering typically right away. Downsides are that that incision in the palm can be kind of painful, sometimes requiring people to have therapy after. But I'll tell you this, if the finger continues to trigger and the person has to continue to pull it out, there is a risk that the tendon will eventually rupture. So if you have trigger fingers, I would definitely suggest, if you are able, seeing somebody that can send you to a therapist that can at least immobilize and take the pressure off of that tendon, and see if you can get the problem fixed that way. And if they can't, then good hand surgeon, fast, easy surgery, but one that would definitely be needed.
Okay, thank you. Question, could you compare the symptoms of basal thumb joint arthritis with those of carpal tunnel?
So yes, I can. And I will also tell you, they are often associated with each other. So, arthritis is a problem with age, right? And so is carpal tunnel. But osteoarthritis and rheumatoid arthritis and diabetes all have an increased risk of carpal tunnel. So, so arthritis is typically achy pain, and a lot of times will subside if you put it at rest, or if you stop doing the activity. Carpal tunnel, you're going to have more electrical shooting pain, more paresthesias coming into your hand, some achiness at the wrist, but paresthesias coming into your hand. And then, like I said, often, people's first complaint is I keep dropping things. And so less sweating at your fingertips. And like I said, one of the other things is that it's not a surprise if you go in and the doctor x-rays you and goes, you have some thumb arthritis. And you'll say, but I have numbness and tingling in my fingers. Oh, we have carpal tunnel, but you have some thumb arthritis too. Carpal tunnel, easy surgery gets rid of the problem. Now, here's the other thing. With carpal tunnel, if the compression is not relieved, it will continue to get worse and you will lose the muscle function some of the muscle force and function at your thumb. Once that happens, they can't get that muscle, typically cannot get that muscle back. So, a real severe carpal tunnel really needs to be evaluated and relieved. I hope I answered that question.
Okay, if there's any more questions about that, I'll let them follow up on that. I had one question about finding a hand therapist, and this particular person was in Indiana, but in general, what would be your recommendation about how to find a hand therapist?
So the hand therapy, there are two places, but the Hand Therapy Certification Commission, HTCC, Hand Therapy Certification Commission. You can Google that. If you go through their website, there's a place that says find a hand therapist. You can look by state, city, name. There's an entire directory of therapists. And if you're in Indiana, Indiana Hand Center is probably the foremost hand center in the United States. So, I mean, they wrote the books.
And I did just put that link to the HTCC Find a CHT page
Yeah.
there.
Yeah.
You can look on the directory there. Looking down the rest of the questions. This one, I have times when I'm pushing my wheelchair and all of a sudden trying to put any pressure pushing my wheels, I have major pain in my wrist to the point where I have to stop pushing for a little while. A minute or two, then goes away, only happens once or twice a month. Any ideas? Happens more out in rough areas like grass or gravel.
I would bet, and I'm just going to assume that the pain is right in here. There's, and I'll, how am I going to say this? There are two tendons that come through a very small space right here that are susceptible to compression, especially when people do this often. I'll tell you, the person that discovered this problem discovered it, I think, in the 16th century from from Italian fishermen from this particular position. And what happens is that repeatedly doing that position will cause pain and compression of those two tendons. The way to often know if it's those is to put your thumb in your palm like this and then deviate your wrist towards the thumb. If that causes pain, then it's likely it's called de Quervain's. I don't know if you can put that in the chat, Paul, but it's DE and then capital Quervains. It's a very big problem for wheelchair users. It's a big problem for people that do that motion repeatedly. One of the things that's helpful for it is splinting, but difficult to immobilize if you're using a wheelchair. So if you go back and look at that Comfort Cool splint that I put in for CMC arthritis, that might be a good bet. It might help relieve that, or give some support when you're doing that particular activity.
Could you spell that again, please?
Yeah, capital DE and then capital Quervains. Was named after the guy who described it.
Okay. All right, I'm going to put something on there from Mayo Clinic in the chat. And there we go. Okay, we are at the top of the hour, past 2 minutes, a little bit. And I don't see any other questions, and just excellent presentation there, Dr. Siegel, and
Thank you.
it's very expert information. Got a couple other, I think people are saying thank you. Yes. So I do have one more I'll throw out. I know people have to probably take off, but I'll throw this one out too. Disassociated scapoid heel. Will a disassociated scapoid heal on its own?
Not that I know of.
Okay.
I would definitely visit a hand surgeon. Now, that doesn't mean that you have to do anything about it. A lot of times therapists can strengthen and um, get a way to get around the problem. But once it's disassociated, once the ligaments are not there, we can't therapists can't put it back. That's it. That's the hand surgeon's job. Definitely can go see somebody for strengthening though.
Okay, great. Again, thank you, Dr. Siegel, and thank you to everybody that participated today. We appreciate your feedback on the survey. And again, we are going to be archiving this on our website. Plan to send you out a link when that's available. This was the last, as I mentioned, in our series of NTW archived webinars, or excuse me, encore webinars. You are all on the listserv if you participated in this. So for future webinars, we will plan to let you know. And I'll leave the chat open for a little bit, leave the room up for a little bit in case you want to check out any of the links and resources. Thank
Thank
you
you,
again.
everyone.
Have a good day.